Welcome, everyone, to another edition of SCRC's Let's Talk Caregiving. I'm your host, Roberto Velasquez, President and CEO of Southern Caregiver Resource Center, and I'm here as always with my co-host, Martha Rañón, our Executive Vice President. Hi, Marta.
Hey, Roberto.
Today we have a very special guest. Her name is Dr. Kathryn, or Katie as her friends call her, Winters. Dr. Winters is a palliative care physician and an assistant professor at UCSD Health. Her clinical work is centered on serving patients who are suffering out-of-control symptoms related to complex and often life-limiting illnesses, as well as tending to the emotional pain that comes with a medical crisis and or the end of life for both patients and their loved ones. In addition, Dr. Winters holds an appointment at the UCSD School of Medicine, where she mentors and advises about 100 students. Katie earned her medical degree from UCSD School of Medicine in 2013, then completed an internal medicine residency at Johns Hopkins Bayview Medical Center in Baltimore in 2017. Following residency, she returned home to San Diego to complete a one-year hospice and palliative medicine fellowship at UC San Diego and Scripps. She joined the faculty at UCSD Health in fall of 2017. We're so happy to have you join us here, Dr. Winters, or Katie, if you prefer. This is such an important topic that we want to talk about: end of life, palliative care, how it works, how it helps both families and the individual with the serious illness. And so we're just so thrilled that you're here.
Thank you so much to both of you for having me here today.
Dr. Winters, it's really a pleasure to have you here. And I really wanted to talk about this topic because I know that with caregivers, for example, the caregivers that we see, that we serve, that I've talked to, there is a lot of confusion and almost hesitation when it comes to accessing palliative care, and a confusion with hospice care. So I wanted to really discuss this for our listeners to kind of understand the difference, but also how to access that kind of service.
And to go along with that, Martha, also, how does it get paid for? I mean, we know about hospice care, and it's covered by Medicare and other types of insurances. But palliative care, a lot of our listeners might not know how to access that and how it's covered. So again, so glad you're here.
Yeah, thank you. And right away, you're bringing up both of you really important issues that we encounter in the clinical setting all the time. I think I'd like to start by talking about what is palliative care, and within that, what's the difference between palliative care and hospice care? Because this question comes up. Sometimes people feel nervous. They hear the word palliative or hospice, and they feel very nervous that this means something really negative about their prospects for their health or their well-being overall. So I like to think about palliative care as a big, broad umbrella term. And the focus of palliative care is a medical specialty. And the focus is symptom management for complex symptoms like pain, shortness of breath, constipation, trouble sleeping, anxiety, things that really affect your overall quality of life and well-being, and things that are often prominent when you're dealing with chronic or serious or life-limiting illness. And then the other part of palliative care is really providing support, whole person support, to both the patient who has the illness and their loved ones or their support system, their closest people who are giving them caregiving or emotional support. So it's those two arms encompass the practice of palliative care. And palliative care can be administered in the clinic setting. So you go and see your oncologist in the clinic. You can also go and see a palliative care team in the clinic. And you can do that when you have many years left to live. So it doesn't need to be at a time when you're really close to the end of life. It just needs to be a time when you could benefit from symptom management and support. So that can be at various times when you're dealing with serious illness.
Katie, we deal a lot with older adults. They're family caregivers of older adults, and many of them, about 80% of our clientele, our family caregivers, are providing support to loved ones with dementia. And I believe dementia is one of the conditions that palliative care can also assist in. And how does that work with palliative care? Because a person with dementia can live for years and years and years. So do you have some examples you can share with us about how it works with dementia?
Yeah. I am thinking about patients I've seen in the hospital setting and in the clinic setting with a diagnosis of dementia. And sometimes that's an earlier diagnosis, and sometimes it's a later, at a later point in the trajectory of that condition, that illness. And the way that palliative care can help is really tackling some of those symptoms, like I mentioned. My experience treating patients with dementia is often there can be issues with agitation or anxiety, insomnia. Those things can really impact quality of life and a person's ability to meaningfully connect with their loved ones, for example. So, palliative care can help with those things. In addition to other symptoms if they're present. And then palliative care, the unique thing about that medical specialty is that it's really, by definition, it's an interdisciplinary team that should be seeing patients and supporting their families too, their caregivers. And so what that looks like in practice is often on a palliative care team, as well as a hospice team, you'll have a physician, maybe a nurse practitioner or an RN. You'll have social work present, hopefully, spiritual support, a chaplain of some type. Sometimes you have a psychologist, a psychiatrist, a pharmacist. Varying levels of robustness exist for teams, but that team approach really allows for a more comprehensive and a stronger support for both patient and family. So then what that can look like is if you are visiting your palliative care team in the clinic periodically over the course of months or even years, well, that team gets to know everybody and gets to walk alongside you as you're dealing with issues like, hey, I need help getting time off work for caregiving, or I'm having new symptoms. How do we tackle that? Or, various things.
I am really wishing that all of the medical field really would take this concept of interdisciplinary approach to the care of the patient, because as we know, especially in the organization where we do this work, the caregiver is not part of this factored into this solution. And we find that many times caregivers, even though they're the ones that are taking them to the medical appointments, the pharmacy, administering the medication, they're often overlooked and really should be considered as an asset to the medical field, the interdisciplinary team, but also the care of the person, the patient. I'm just really glad that the palliative approach, as well as the hospice approach, encompasses all of this holistic, group. I really wish that it were the case for all of the medical, systems.
I wish that too.
Yes, and what's really interesting to me is, and even all the years that I've been in health and human services arena and working with older adults and Alzheimer's and caregivers, we never really think about palliative care unless it's connected to hospice in some way. And hospice, of course, we know is end of life, 6-month prognosis. So people don't think of even thinking about palliative care or don't know about it. And so it's really interesting that it could be for years that you're getting palliative care. How does one get connected, or how does a referral go from the doctor to the family, or the family requesting palliative care?
Yeah, that can happen both in the outpatient, the clinic setting, as well as if you or your family member is hospitalized. You can simply ask. You can say, "Hey, we're dealing with a lot of symptoms, or we're needing a little bit more support as we're on our journey with this medical crisis or this ongoing medical issue. Uh, are there palliative care services available?" And at most of the major health systems that people are going to be accessing, there's going to be a palliative care team, hopefully. And even if there isn't, there are standalone palliative care programs in the community. So it's really just a referral to a specialty service, just like any other kind of specialty service. So if your primary care doctor, diagnosed you with a movement disorder and then referred you to neurology, well, your neurologist or your primary care doctor could also refer you to palliative care. Or if there's a cancer diagnosis, often oncology departments are working closely with palliative care departments. And again, that can happen inpatient or outpatient, really. That's a really common scenario. And typically, these services are covered by insurance, just the way your care from your neurologist or your oncologist would be covered similarly. It depends on the individual insurance and all of that. But the usual practice is that this is something that's covered under normal benefits.
Katie, do you often see patients who are receiving palliative care and then their conditions improve, their symptoms management, so they actually are, I mean, and I'm talking about more the life-limiting types of conditions, right? Like a cancer or end-stage Alzheimer's. And I've been witness to clients who actually their symptoms get so well managed because of the whole entire multidisciplinary team and all the attention and the pain management and other types of support that they get, that the individuals actually live way longer than they thought they were when they first started getting the services. Have you seen that?
I haven't seen a lot of that, to be honest, although there are these cases that exist with good care. Of course, we hope to extend quality of life and quantity of life, both. Um, I've done the majority of my clinical work since I started at UCSD in 2017 in the inpatient setting. So I'm usually seeing people who are hospitalized in the midst of some sort of crisis. So I don't have the benefit of that sort of long-term, lower, acuity sort of situation following people over an extended period of time. But I would say, to your question, the beauty of palliative care is that pretty much, if you have symptoms that need to be managed, you qualify, or support that's needed, you qualify for palliative care, versus the hospice benefit as defined in our healthcare system. That benefit is specific, as you alluded to our best guess is that your prognosis is 6 months or less, and that has to be vetted over and over again to continue to qualify for that. And so I have seen, especially when I was in training and doing hospice work out in the community, where people would quote unquote graduate from hospice care, meaning they're just living too well and too long to continue to qualify for that benefit, which can put, patients and families in a bind because suddenly you don't qualify for all the good care you were getting. But that's, a predicament, unfortunately, that we put patients and families in, but maybe a better one to have than a quicker descent.
So, Katie, how would a family member prepare for kind of transitioning into palliative care? I know that many times, I think a lot of caregivers want to fix whatever's going on with whatever ailment their loved one is experiencing. They want to take away all the pain and the discomfort. But sometimes it's not possible, and so you go into palliative care. But what is it that the caregiver then? How do they prepare?
Yeah, so I think a caregiver could prepare for engagement with palliative care by really taking a mental inventory, sort of what is impacting our quality of life right now. Is it difficulty with eating, sleeping? Is it financial stuff? Is it spiritual concerns? Is it advanced care planning, thinking about that realm? really taking that inventory with the support system and the patient, and then bringing those issues to the palliative care team so that they could then triage and help problem solve within that. I think that the beauty of palliative care is that you can receive palliative care support and medical care through a palliative team alongside treatments for your cancer, treatments for your dementia, treatments for whatever the chronic or life-limiting illness is. So there's no exclusion there. A good palliative care team will just provide support for all the other good medical care that you're getting at the same time. So it's not really giving up anything in order to receive this extra layer of support. It really should be an extra layer.
Oh, that's wonderful to know. I think that would make a difference with a lot of caregivers who might be thinking it's either one or the other.
Yeah, and that's a misconception that comes around because our hospice benefit, as defined by Medicare, it requires you to not be receiving disease modifying treatments for whatever that diagnosis is that's the life-limiting diagnosis. So that, in a way, often feels like giving something up in order to receive something else, but that is not the case for palliative care.
That's incredibly important for families and our listeners to know because, again, I just think that most people think of palliative care as it relates to hospice. Palliative care and hospice, same thing. And it's so different. The goals are so different. And but they do go hand in hand. But it's really nice for us to learn that you can access palliative care way before you need hospice if you have conditions that require symptom management and I really like the piece of the whole person and family engagement because, again, as Martha was saying earlier, the family are the ones that know the individual, especially if they're dealing with somebody with cognitive decline, dementia, things of that nature, where the family caregivers becomes the advocate or spokesperson, so that they're being listened to. And I just love the fact that it's not taking away other treatments or other conditions, whereas hospice, again, is focused for end of life only. And palliative care can help out families as soon as they're starting to have real serious symptoms of conditions.
I just wanted to see if Dr. Winters, you have any other last minute, suggestions or guidance for our families who might be facing this decision soon in their lives.
Yeah, I do. I think if you are facing this part of life with a chronic or a life-limiting illness, there's low risk in at least having a consult with a palliative care clinic or a team. You just ask the main team that's taking care of you, whether that's the neurologist or the oncologist, et cetera. And then you could have a clinic visit, see what they have to offer. And it really can be an extra layer of support that can impact and improve quality of life for whatever time is remaining.
Yeah, that's fantastic. Thank you for that final advice. Well, that's all the time we have left for this edition of Let's Talk Caregiving. To hear more of our podcasts, follow us on your favorite podcasting platform or visit our website at scrc.care. I want to thank Martha for co-hosting another important discussion, and our guest, Dr. Kathryn Winters, and our audience for tuning in. If you're providing support to a loved one, you don't have to do this alone. Asking for help is not a sign of weakness, it's a sign of strength. To connect to our programs and services, visit our website at scrc.care or call us at 1-800-827-1008. If you live outside of San Diego and Imperial counties, visit caregivercalifornia.org to connect to the Caregiver Resource Center nearest you. To support our efforts and make a tax-deductible donation, please go to scrc.care and click on the Donate tab. And remember, SCRC is here for you,
caring for those who care for others.